morning and welcome to the next in our series of applying the Brain and Mind Centre's Youth Model. I'm joined this morning by Professor Elizabeth Scott and I'm Professor Ian Hickie from the Brain and Mind Centre. Today we're going to take 3 case studies that work our way through the Brain and Mind Centre Youth Model. So, go to the next slide. Just like to recognise the traditional owners of the land we're on, which for the Brain and Mind Centre in Camperdown is the Gadigal people of the Eora Nation and their centuries of learning and teaching on those lands, and also those with a lived experience of mental health problems. Next slide. So in the seminar series that has preceded this particular series of case examples we're going to go through, there have been 6, and they've worked their way through a highly personalised and measurement-based model of care, combining clinical stage and pathophysiological mechanisms, a comprehensive assessment framework, how to personalise care options with the concept of best care first time, how to develop a service model to go with that individual delivery of care, and then how to use new technologies to both enhance assessment, provide additional options, and then track care over time. Next slide. So, in Seminar 1, we discussed the multidimensional framework in which we do assessment, the movement away from just individual diagnoses and continuously talk about individual diagnoses, within the illness category to talk about type and stage and trajectory, importantly to emphasise social and occupational functioning, concurrently suicidal thoughts and behaviours, comorbidities in relation to alcohol and substance abuse, and concurrent physical illness. It's complex. It's not simple, but young people's lives are often complex, and the number of issues that need to be attended to and seriously assessed and intervened need to be adapted. Next slide. Importantly, we don't focus on individual diagnoses. We focus on those large pathophysiological pathways. And there are 3 that we're particularly preoccupied with. A neurodevelopmental one that may result in increased risk of psychotic type disorders in adolescence. The hyperarousal or anxiety depression type framework gives rise to common forms of anxiety and depression, and circadian rhythms or body clock type disturbances that often give rise to bipolar type disorders. In addition to those pathophysiological pathways and illness trajectories, we're very interested of the concept of clinical stage and the extent to which staging may actually add on to those pathophysiological pathways. So we see different symptom clusters coming together at different stages of illness to develop the more common syndromes that we see in our diagnostic manuals. Next slide. In order to do multidimensional assessment really well, we strongly favour the inclusion not just of clinical instruments, but of standardised self-report and other objective measures, and that people make actual recordings using standardised instruments on an appropriate way, so that you can actually keep track over time of a young person's status in each of these key dimensions that we've just outlined. Once you're doing that, you don't just do it once, you do it repeatedly over the course of illness. So you end up with a complex but straightforward and well-recorded framework for monitoring response to care. Next slide. Having this notion of where an individual goes over time is really important. So what we like to talk about is the stages that people are in, or the episodes they're in, what strategies are required to get out of those episodes, the ladders, if you like, of interventions or treatments, and then what sorts of planks are required to prevent falling back into those holes again in the future. What are the secondary protective mechanisms that are involved in the secondary prevention strategies that we like to take forward? So at all phases for young people, there's getting out of this episode, and there's actually preventing recurrence if we can, and certainly preventing illness progression if that's possible. Next slide. Moving from the individual to the services, there's an issue about how long and how complex a service is. And they need to use multidisciplinary services. They need to have a variety of different people, provide different levels of services for different intensity and duration in order to achieve really good outcomes. One of the driving forces behind the development of the Brain and Mind Youth Model has been our awareness that services are often not multidisciplinary, not delivered long enough to achieve really the desirable outcome: return to school, return to work, improvement in overall health over time. Next slide. Once you've got this degree of complexity, multiple assessments being managed over time, multiple people as part of a team needing to deal with different parts of a young person's care and needing to bring that care together in a sensible way, it becomes pretty obvious that using standard medical records and standard assessment systems, or just having individual clinicians try and hold an idea in their head, no matter how good they are, the use of digital platforms may well contribute in the future to actually the engagement with care. As emphasised by a number of the young people that we've shown in the earlier seminar series, that becomes really important in terms of their participation in their ongoing monitoring and care, and giving them more options that they can take themselves on an ongoing basis. So they're the 6 seminar series. If you haven't had a chance to see each of those, I suggest that you actually take the time to work your way through those to understand the complete ramifications of that framework. So what we'd like to do today now is move on to a number of individual case examples. When we bring all those together, if you see back to the previous slide, when we bring all those together, you do see that complete framework which you've outlined in the Medical Journal of Australia supplement in October last year, which brings the assessments, which are multidimensional framework, clinical staging, pathophysiological pathways, and illness trajectories, together with measurement-based care, real-time monitoring, and a focus on outcomes as being the key factors. Keeping that concept in mind throughout as we discuss each of the cases gives you some degree of the complexity of the decisions that need to be made during each time that a person enters an episode of care, and then hopefully moves on to recovery and prevention of relapse or prevention of progression of their illness. Next slide. So there are 3 case studies we'd like to bring forward today, each to indicate different stages, different degrees of complexity, and different types of problems that are presented. Each one highlights the need for all of those factors: multidimensional assessment, consideration of pathophysiological pathways, consideration of clinical stage, routine outcome monitoring, and the ways that technology can be used in practice. It sounds like a lot, Liz, but what do you think? Is it perfectly reasonable to try and keep those ideas in place through the management of each person, no matter the stage of illness or the severity of syndrome they originally present?
So if you think about it in terms of the efficiency of care, actually having some algorithm that enables you to identify the needs that the young person has, how to what interventions are required, how to track that over time, and to actually see, which is I think the huge innovation, to be able to see what the impact of those outcomes are in real time. Do the treatments that we provide actually work? And if you think about the number of young people who arrive at a service, they get the treatment of the service, the treatment of the day, the treatment that service can provide, without necessarily knowing what the long-term outcome of that intervention is. Really, if we think about how to use our services more effectively, use the money and resources that we have, which are always scarce, then this is obviously, I think, the way to go in the future.
As more people come into care, which will be the case and what's happening in the case prior to COVID-19 and subsequent to COVID-19, more young people will come into care because of further disruption to their lives. We recognise that all of those people have a need for care. And that need for care is likely to be multidimensional, even if the syndrome they have is not at its severe or it's the first time that they've experienced it. So trying to work systematically with everybody, but then trying to match the level of intervention and the intensity of intervention to their actual needs is the goal. So next slide. One of the issues I just want to reinforce as we go into each of the cases is an importance we put around clinical stage, which is not age or age of development, it's the stage of illness and is critical. People think this is very complicated and not necessarily easy to apply. I'd like to emphasise actually in young people, it's pretty straightforward to apply, but its implications are fairly profound. Just a few rules. When we do stage people, if there's uncertainty, we stage down, not up. Another is once you develop a certain stage, you can actually stay in that stage, you can recover from that stage, but you can't go backwards. Just like staging in cancer and other areas, once you've developed a certain level of illness, you can't ever say it didn't happen. In fact, it tells you about the vulnerability of the person during this episode, but also for the future. This simple approach of how to apply that staging mechanism is worth holding in your head. It's pretty straightforward. The key first decision, the key point is the person already reached a stage 2, which is a full threshold major discrete mood or psychotic syndrome. If not, then they're in stage 1. And then within stage 1, if they're at an early stage and it's rather non-specific, then they're at stage 1A. If they've developed some specific features of a major syndrome and it is more severe and impacting on their life and causing more dysfunction, then it's a stage 1B. And the great majority of what we see fits into those 3 stages. For those who've got more persistent and ongoing disorders, they can then be staged on an ongoing basis into stage 2, 3, and 4. But in the youth mental health world, these key differentiations between the first full threshold disorders, the stage 2s, and the earlier stages is the key differentiation. Clearly, in the earlier stages, we're trying to provide as much psychological, behavioural, social therapy as possible and constrain the inappropriate or overuse of medications within those particular periods. We're trying to use all that's available, however, to prevent progression to later stages. And we have validated this particular framework in terms of differential risks of progression. So those in 1A have only about a 5% risk of progression over the next 2 years to a more severe disorder, to a stage 2 disorder, sorry. Those within stage B, about 15%. That's still quite a large number. You know, you're going to need basically 1 in 5, 1 in 6 of those people who are in stage 1B are at risk of going on to develop a full threshold syndrome. If we can prevent that, that's what we need to do. If you think that in terms of numbers needed to treat, needing to treat about 5 to successfully prevent 1 progressing, compare with the rest of medicine in other areas where you're trying to prevent stroke, you're trying to prevent heart attack, you're trying to prevent other progressions. That is a very acceptable number in terms of the numbers needed to treat. Next slide. So let's talk about Jane. She's 17-year-old, particularly around the times of end of school exams type frameworks. She comes to one of our early intervention services, Headspace, requested for parents. They're worried about increasing anxiety in the lead up to the final school exams. What do you think, Liz? Every October, November?
It's an extremely common occurrence, about to start to escalate now as we go into trial exams and running up to the kind of HSC exams.
So she's having trouble sleeping, experiencing fatigue, getting in the way of her ability to complete schoolwork. She had a poor performance in the trial exams, feels a sense of failure, excuse me, and now has reluctance to go back to school and talks about leaving before sitting finals exams. Needless to say, parents in that situation, panic, get help. Good idea. And there's a context for some urgency in this particular situation. Now, really important to say about our assessment of these situations, that's the narrative, that's what's happening, that's the situation that's driving her presentation for care. There is a danger in our world that we feel the narrative is the explanation. Common in this situation, that the HSC or the end of year school exams cause anxiety, and to pretend that the young person may never have had anxiety before, as distinct from this is the external situation which is exacerbating an underlying vulnerability to have this type of difficulty. So when Jane presents for assessment, she denies having sustained low mood, but is anxious and pessimistic about her future. Really critically, the issue of mental state examination, how does a person look, behave and interact, is a much more critical clinical assessment and critical to staging. So staging itself does require that aspect of clinician to be added to the story as we understand it. So in terms of her mental state of examination, she's normal weight, she's neatly dressed, she's in a school uniform, she reports feeling nervous, her eye contact is intermittent, she's shifting around as young people will classically, who's anxious and upset about being in the situation. She appears logical in her interactions, although she's complaining about difficulties with the cognitive function. She doesn't show any evidence of change in that cognitive function, but she does do what people with anxiety do. She's catastrophizing her future, can't see the room. How many young people like this would you have seen, Elizabeth?
Countless. Very. And out of those groups, it is trying to understand for whom this is going to be transient and may well be related to the current stress. But as you say, for the large majority of people, they've already been in trouble previously, but this has been the event or the stressor that has really brought them into care. So it's understanding much more about the trajectory that they've been on to be able to understand what is the level of intervention they require.
So important to remember that the age of onset of many of these particular problems, particularly anxiety related, is actually in early adolescence, often becoming more severe in mid-adolescence, around 15, 16, with greater challenges in school and greater challenges in the social environment, but then often presenting for formal care in a particular situation like end of school examinations and the heightened tension around that. So in Jane's history, since the beginning of year 10, she has been isolating herself more and more. Pretty typical story for someone with significant anxiety at that age, more social anxiety, more difficulty coping with school challenges, actually withdrawing more from her friends, not interacting that particular way. So importantly here, this has been going on for some time before the event that's precipitated her presenting for care, being the final school exams. Not surprisingly, in young women, her parents have also observed disturbed eating behaviours such as binging and recurrent dining. You want to comment, Liz, on the amount of disturbed eating behaviour and disturbed body image? That isn't necessarily an eating disorder. Yeah. That is within the context of otherwise anxiety, particularly in young women.
So certainly in terms of our Headspace clinics, the rates of disturbed eating without reaching a final or formal kind of diagnostic category for an eating disorder is extremely high. So it goes with anxiety, with stress, with perfectionism, with more depressive symptoms. But these are very common symptom clusters that we see across a range of diagnoses.
When we're looking for other things that may be predictive, family history is an important consideration. While many people do not have a family history of any specific disorder, it is quite common. If there is a very specific family history, it may increase our concern about a young person progressing to a more severe disorder. In this case, as a young man, Jane's father was diagnosed with social anxiety and did what many young men often do, used alcohol to cope. So a family history of anxiety, particularly social anxiety, not unusual. Interesting in this situation in her dad. Next slide. So when we use the whole dashboard of results here, you can see in the top left, Jane's identity. What you see in the dashboard on the bottom left is a brief summary of where she's at, moderate impact on her everyday function, more extreme impact on her social connectedness, and a real worry when you see young people disconnecting, not expressing suicidal thoughts and behaviours, and moderate impact on her mental health. Interestingly, using the wider dashboard, something not picked up during her initial assessment was the fact that she had moderate tobacco use, which she hadn't disclosed previously, but like commonly people do, she disclosed that during the wider set of assessments. Her health priorities really have picked up around social disconnectedness, her degree of anxiety, and her poor sleep-wake cycle. So in terms of her prioritisation, they are the main areas of focus. Next slide. So what we need to decide then is what stage that Jane is actually likely to be at this point. So the critical clinical decision is, does she have any characteristics of a stage 2 disorder? And the fairly simple answer to that is no, that she doesn't. So the next decision to be made then is whether she has features that are more of an attenuated syndrome, more specific, depressive, anxiety, at-risk mental states, psychotic-like symptoms, hypomanic-like symptoms, or comorbidity, as well as considerable impact on functioning. She's expressing fairly straightforward sets of anxiety that we would generally recognise, so we would assign her to stage 1A. Fairly straightforward. She has an obvious need for care and impact on functioning, trouble completing her exams, but largely has a fairly classical anxiety type phenomenon with only moderate impact on her functioning and largely characterised by fairly significant anxiety in a particular situation. So for us, she's of the type that's of anxiety, of hyperarousal, reactions to particular life stressors, in this case, exam anxiety, which puts her in the hyperarousal category. And then in terms of the symptom sets that go with that, nervousness, feeling stressed, poor sleep quality, coming together as symptom sets within that 1A sets of categories. So she's within that pathophysiological path. She's at a relatively early stage. So this is the sort of thing then that we would present to young people and their families. It well captures the symptoms that she has, the general pathway that she's had of social anxiety throughout her development, now exacerbated in this particular situation, but at a relatively low level of risk at this particular time. Something we would expect to be able to manage with the appropriate psychological and behavioural interventions in the first instance in this particular situation. So if we go to the next slide, we look at care options in this particular thing. We've now taken into account the multidimensional assessment, the illness trajectory and clinical stage, She has a need for care, which is obvious, and a reason to track that over time. We need to make sure she gets through these exams, through this particular period, and that actually the anxiety comes under control and she moves back towards successful functioning. So the hole she's in, it's not a really deep hole at this point, but it requires the range of appropriate cognitive behavioural strategies that might be appropriate. This will depend on the availability, but fairly classically here for anxiety related to her own particular situation, control of her own thoughts, control of her own arousal, probably engage with particular problem-solving strategies. They will require actually focus on her sleep-wake cycle to help to improve the situation. And then to continue to use those strategies on an ongoing basis to get well. But first, got to make sure she gets out of the hole, gets through the exams, completes that particular things. Often in an exam situation, one comment was about making sure with schools, with parents, with others, that she does actually get through the exam situation and copes with, not has everyone else have her not do it or avoid it, but assist her to cope with it to pass successfully through that particular phase.
Yeah, that's a really important issue. So obviously for her, remaining in the school system and actually completing her HSC is going to give her the ticket that she requires for the next stage in life, whether that's a vocational course, whether it's university, whether it's just, looking at, the next opportunity in terms of jobs or return to study later in life as a mature student. It gives you the ticket. It also gives you the social structure, maintaining connection with friends and with your social system. And the other important issue is about the exposure tasks. If avoidance becomes the predominant coping strategy, you become more and more anxious and more avoidant, and that's going to translate into your next stage of life. So actually going to school, sitting exams with support of the school and teachers and family is an important exposure task for managing her anxiety.
So in addition to the assistance she may receive clinically from the appropriate person with the appropriate psychological skills, appropriate education support, there are also online type options, and issues like Smiley Mind and using mindfulness, using other particular types of online tools for a sleep-wake cycle for others of her particular interest, including her eating behaviour. There's a range of other online tools you might introduce her to. The dashboard shown in the Interwell platform shows clearly what stage that she's at and makes this obvious to her and her parents. We think she's a very early stage, but at the moment she has a moderate need for care because her anxiety has become severe in the context of a particular major life challenge. So what you'd hope in this situation is it provides a summary for Jane and for her family, where she's at, what type of problem we think she has, what sorts of resources are required, and that monitoring of the outcome, even though this is early stage, got a particular context around school, making sure that actually throughout this particular period and then on to her post-school life, that she actually has skills that she can use and actually deals with these particular issues and fully recovers. Just take an earlier note that the issues around social withdrawal and anxiety and avoidance are actually quite well established. She's been doing that over the last 2 years. You'd want to see that change because guess what comes next? Post-school education, whether that's in university or in life or in other training courses, are likely to be more challenging than school has been. So the last thing in the world you want to do is go on from this early pattern of avoidance to then avoiding engagement with post-school employment, educational training. So important to see you take the opportunity at this stage to try and get it right. Next slide. Okay, on to the second example. Slightly older young woman, Anne, aged 22, in her third years of studies at university. She's come to the university counselling suggestion, suggested one of her tutors who noticed that she was teary and asked why she didn't submit her assessment on time. So we're into that classic kind of post-school kind of situation, more challenging, people noticing that somebody's not functioning. She's currently in a share house, has become more withdrawn, believes her friends and others are talking about her ugly Eurasian appearance. She's also drinking heavily, has begun to self-harm and has some suicidal thoughts. So here you have that classic situation of other people really noticing that the person's really not functioning in a post-school environment, despite they've actually transitioned successfully from school to that period and appears to be deteriorating in functioning, more self-preoccupied, more withdrawal, more alcohol and other comorbidity, more other coping strategies or comorbidity developing that actually suggest actually greater risk. So when she comes to care, you see someone with low mood and a real loss of pleasure in their usual activities. Important in this situation, again, the notion of her mental state. She's slight. She's wearing loose-fitting clothing. Hair is growing out to cover her face. She's more withdrawn. She's obviously bright, but she seems distracted, asking many questions to be repeated, needing to go over the same sorts of materials, not so easy to actually interact with. She's reporting some odd ideas about her Eurasian appearance and some feeling that her friends think that she's ugly. There's no actual hallucinatory experience, but rather odd thinking about her appearance. She's tearful, but responsive to the interpersonal type environment. Interesting in terms of her past, she's now 22, but she was previously treated for a major depressive episode at 18. So she's a previous episode, at least a significant depressive disorder. She's got a prior 2-year history of increasing social anxiety and panic attacks. So again, some suggestion this has been going on for some period of time. Pretty typically, Liz, we do see people 2 or 3 years after school has finished with more severe disorders. Do you want to just comment on that presentation 2 or 3 years later? Why does it take so long?
I think, a lot of it has been about access to care, that young people haven't necessarily known where to go for care, or access has been extremely limited, even with the Headspace sites that we have. We also know from Headspace that many people present for care, but have maybe 1 or 2 sessions of psychological therapy and then drop out of care. So the dose of the intervention that they get is relatively small. So I think it says a lot about our access. It says a lot about how we assist young people to navigate health systems. And it says a lot about the branding and the acceptability of health systems for young people, that they are hard. These are doors, physical doors that are hard for young people to get through.
So this is also not atypical for us to see someone who's had a number of prior brief episodes of contact with care, continuing psychological symptoms, continuing deterioration in function, but they've tried to carry on. She's tried to carry on with her university studies, but at this point is attracting more attention from others about it isn't going well and deteriorating. You can see, in a sense, being pushed to come for care. Do you want to just comment about the odd ideas, Liz, about her Eurasian experience? She is of mixed European and Asian heritage and feeling that she is ugly and that people are talking about her.
Yeah, so this obviously requires further evaluation. Is this something that is related to her idea of herself and her self-esteem, related to ideas of issues of perfectionism and negative or irrational thinking, or is she developing is this indicative that she might be developing a psychotic type illness? So are these related to anxiety and a way of thinking and her schema, the way that she sees herself and sees the world, or is this related to more unusual ideas that are developing that are indicative of a more significant illness down the track?
So of course, one of the differences at this point, we may not know.
Yes.
So the expression of odd ideas and the somewhat distracted behaviour during the interview and having the questions continuously repeated, continuously to be reassured about particular things, but actually not being reassured when challenged about those sets of ideas would create a question mark, distinctly requiring further consideration and further monitoring. Sometimes people think they must get the answer on this occasion. If you just keep pursuing the person, you can be absolutely certain one way or another. Of course, in many of these situations, we cannot be certain. We're just noting that it's a concerning feature. Could be associated with anxiety, and most situations would be explained by excessive anxiety about body appearance, but could be slightly odder than that. Just in terms of family history, the only family history note is that her dad had a pancreatic cancer, but no other family history of mental health problems. Next slide. So if we look at her particular profile, one of the really interesting kind of issues is that she didn't actually express during her in-clinic appointment was in relation to her sexual identity, that she identifies as being same-sex attracted. Another interesting kind of consideration in terms of the development of identity during this particular period. Very common, in fact, in our Headspace style services for people to actually express issues related to their sexual identity during this particular developmental period. You can see in terms of her dashboard, a whole lot more red, and certainly the decline in social connectedness, the emergence of suicidal thoughts and behaviours being a concern, the issues of risk being a concern. She has started self-harming in this particular context, impacts on her daily function and on her overall health. In terms of her health priorities, clearly the suicidal thoughts and behaviours and self-harm are very prominent, along with increasingly depressed mood. So Liz, in this particular kind of situation where people start to actually express that degree of risk as well as an odd mental state, what sort of issues are you thinking about at that point?
So I'm certainly thinking that this is a person who's going to require a more intensive intervention, and that's something that we need to address rapidly. This is not somebody that can sit on a waiting list for a service. This is somebody that needs to be escalated into a level of care that is appropriate for the needs and for the risks that they currently have.
Just one of the issues related to her sexual identity. People always assume that this would have been expressed or would have been pursued during the clinical appointment. Obviously, in Anne's life, there are many things going on. The emergence of self-harm, odd thinking, anxious behaviour, considering using alcohol in a particular kind of situation. It's one of those things that may or may not. And of course, the other thing is people often do disclose to a computer screen, to a questionnaire, when they're actually asked. They put in the answer that is most relevant in that particular situation. So depending on who she had seen, the nature of the interaction, depending on what was prioritised, that particular issue, which may be relevant to this whole particular setting, is disclosed. But at least now we know that that is actually her preferred sexual identity, and that we can consider that can be considered throughout this. Information can be known and be shared amongst those who are involved in the treatment in these particular, if the young person wishes that material to be shared. Next slide. So here, when we look to the clinical stage in the top right, first thing is whether any of these things are at such a point that they would guarantee stage 2. Now, we talked about odd thoughts, the odd thoughts about her appearance. There's certainly degrees of risk, but that's a risk issue, which is not necessarily the same as stage. There's the issues around her depressiveness and the nature of that in a particular kind of ways. But it would appear to us that she does not have any of the defining features of a more severe disorder. So going back to the comments we made originally, in the face of uncertainty, we stage down. So even though she's had a prior depressive episode, she's been treated for anxiety, she hasn't, from our point of view, developed a full-blown major mood or psychotic syndrome. So we put her in the stage 1 categories. However, within the stage 1 categories, she certainly has more severe depressive symptoms. She certainly has odd sets of thoughts to run with those particular depressive phenomena. And there's certainly a degree of persistence here. This is impacted now over several years, and it certainly is having a major degree of impact on her function. So for us, she would be a stage 1B case at this point, looking at the particular features related to functioning and the particular situation that she has here in relation to the depressive has, and degrees of comorbidity with other substance use and other odd ideas. So in that case, she has anxious features and she has some rather odd ideas features. So she sits at the border from our point of view between the hyperarousal, classically anxious state, and some other things would be a little bit more worrying that could be indicative of a more psychotic type state over time. So in terms of the symptom cluster that she has, you see that sense of paranoia combined with anxiety and degrees of avoidance developing as a particular set of issues. That kind of issue about whether people are talking about me, whether they're noticing me, can be often quite hard to sort out. And while the simplest explanation is a social anxiety one, it isn't always the explanation. So at the moment, it's not a simple yes or no. We note it, but we note that she's 1B, and it puts her in that category. She hasn't yet reached the threshold for us for 2, but we'd want to be vigilant. That's in that group that is at some risk of progression. Next slide. So in terms of care options, we see over on the left, we certainly want to make it clear that she's in the 1B categories and that she requires attention to that. She certainly at the moment has a strong need for care in this particular issue because of the suicidality, because of the effect on functioning in terms of what is actually particular area. So in the 1B category, she's going to require more intensive psychological therapy, more intense monitoring, attentions to the suicidal behaviour, to care planning in these particular sets of issues. And we certainly want to make sure that she recovers and that we closely monitor. In the 1B options, we recommend tracking for at least 12 months. That doesn't mean necessarily seeing the person continuously. In the first 3 months, we want to know whether she recovers. Anne's exactly the sort of person that I want to know, not so much whether she gets well, I want to know whether she doesn't get well or she deteriorates in this particular function. So particularly close monitoring in the next 3 months, which can be done with online visits, with face-to-face visits as appropriate in these situations, now becomes important. In addition to the monitoring in terms of other apps and online tools, the issue around suicide safety planning, having a safety care plan, of which there are a variety available, the issues of using appropriate anxiety reduction, see whether anxiety reduction leads to less of her preoccupation about her own thoughts and about her own body image and her own concerns, what actually happens in terms of management so that avoidant sets of behaviours. So in the first instance, appropriate intense psychological therapy combined with online tools and online monitoring becomes very important. Now, she has been quite depressed in this particular context. So if she doesn't respond to care, the issues of, in fact, what will be the appropriate next medical therapies or more intensive psychological therapies would need to be considered. So a case that we would clearly have to keep a close eye on. So Liz, do we keep an eye on such cases, or what do you reckon typically happens to them?
I think, unfortunately, typically what happens is it's very hard for services to discriminate between young people at presentation unless they have high levels of experience in these kind of situations. A lot of it is based on pattern recognition, and obviously the information that you get depends on the questions that you ask. So I think, unfortunately, a lot of people do not come to attention that they require more urgent intervention or more intensive therapy or tracking. Sadly, is the answer.
Okay, the next slide. Okay, so our final case in this particular case is a young man, Simon, 19 years old, from an Aboriginal background. He's already the father of a 1-year-old boy and lives with his girlfriend in a small public housing unit. He's recently withdrawn from both his TAFE studies and his job. He had ideas about becoming an actor, but now he's unmotivated and has fears of rejection. He was previously working full-time, but he struggled to get work on time at all, and he's recently lost his job. As a result of the current situation, where jobs are not easy for young people, he's decided not to look for any other work. Now, this is an important kind of case to consider because there's lots of psychological and social difficulty surrounding such a young man in this particular situation. So here we have to do two things. We have to take account of the severity of the psychosocial circumstances. But that on itself doesn't tell us about him and the nature of the illness that he may have at this particular point in time. So in terms of his presentation for care, he presents as someone who's severely depressed and often does not get out of bed for days at a time. He complains of insomnia, he binge drinks at night to fall asleep. He's also smoking a considerable amount of cannabis every day. He describes his motivation and energy as scarily low and frequently thinks how things will be to just disappear from a particular situation. Now, again, this is where the mental state becomes very important. And of course, there are cultural aspects to take into account when assessing his particular mental state and whether there may be misunderstandings about his mental state as a consequence of cultural differences. However, important to say, during the interview, he slumped in his chair, he avoids all eye contact with a health practitioner. His thoughts and movements are noticeably slow, and he seems to have minimal reaction to any social or emotional cues. He speaks very slowly, has little intonation, and quite a flat and at times non-responsive type affect. So Liz, when you see that kind of thing, even allowing for the circumstances, what does that say to you?
So it has all the hallmarks of a more severe depression of somebody that has more psychomotor change and psychomotor slowing. But also want to know what his concentration and attention and his cognitive function is like.
So in terms of his history, in addition to this being a significant depressive episode right now, he reports throughout his adolescence quite severe depressive phenomena, but also that his mood has been quite unstable from quite low periods to other hypomanic or manic-like periods where he's had increased sex drive, increased risk-taking behaviour, impulsive sets of behaviours. So much more something of a much more unstable mood throughout that particular period. He has previously sought help for depression, previously prescribed an SSRI, previously attended CBT with psychologists. And at reports at those times, those particular interventions did assist him to get through school, that he had some response to those treatments in the past. Importantly, in terms of family history, Simon's mum was diagnosed with bipolar disorder, and there was often noted that there was always suspected that his mum probably had that disorder, often wondered about his own symptoms in that context. Often in a family where someone has a well-documented mood disorder, and you see the emergence of similar types of symptoms during adolescence, the question definitely arises as to whether this may actually be something that does run in the family. The person may be at increased risk. Importantly, Simon's mum has also attempted suicide on at least 3 occasions, so considerable family history of risk in addition to family history of disorder. Worrying sets of considerations. Next slide. So in terms of reviewing the situation, you can see in terms of the indicators on the left, in terms of the dashboard, they're all pretty much in the red sets of categories in terms of impact. The very significant depressed mood and suicidal thoughts are all of considerable concern. Next slide. So, in terms of the clinical staging sets of decisions, for more severe depressive syndromes, the question is whether he's got over the threshold for a major depressive syndrome that is of a more severe and persistent type. And in this particular setting, it's really the mental state considerations that make that decision to say he's a stage 2, a yes at this particular point. So we would assign him to stage 2 on the severity of his depressive syndrome, particularly that related to his psychomotor change, in addition to the impact on his functioning and the degree of comorbidity that he currently presents. Interestingly, he sits at that interface between the particular anxious depressive disorders and those that might be of the circadian bipolar type. So in terms of the pathophysiological pathways, we're putting him in that particular group where psychomotor change, you can see particularly psychomotor retardation, sits with more severe depressive syndromes in the stage 2 type disorders, with a considerable concern that we'd be monitoring him closely as to the possibility that he may well develop a bipolar type syndrome. We're certainly at risk of developing a bipolar type syndrome over time. Next slide. So in terms of care options, we've been explaining that Simon's clearly reached a stage where an ongoing need for serious care is required. Although a relatively young man, he's already been in trouble for a very long time and needing to make sure that he does really well at this point, where he's in serious danger of dropping out socially, becoming high risk, high comorbidity and going onto a very poor path. So we're this sort of person, we want to have a care plan that gets him out of this really deep hole that he's currently in and then seeks to prevent that with the range of psychological and social supports that may well be required, as well as the other sets of issues that may assist him to manage his alcohol and drug use, his socialisation, to keep a close eye on his mood on an ongoing basis. So Liz, do you want to comment often, particularly for young men in this situation who are in a lot of trouble, but also have a lot of responsibilities and a critical transitional point? Our tendency is not to commit, to see them as disruptive and difficult, and to see their social circumstances as being overwhelming, to lose contact with such a young man. What will be the ramifications of losing contact with this man at this point?
It's not only obviously going to be really important in terms of his trajectory, his illness trajectory, as you can see from his mother, who sounds as though she was diagnosed fairly late in the course of her illness, but obviously it's going to have implications for his child and for his girlfriend and possibly for his kind of wider family unit as well. So the risks and the costs of not continuing an intensive intervention and tracking for Simon and his family are huge.
One of the things we really emphasise with the InnerWell platform is the engagement of critical others in actually care. Here, obviously, in terms of Simon's partner, in terms of potentially other family or potentially other adults who may be able to assist in this situation, both in supporting him socially as well as supporting the need for appropriate care, is important. You can see in this type of situation both the really big social risks associated with not providing appropriate care, but also the danger that appropriate care gets lost, that doesn't really happen because of the other considerable social difficulties that surround the situation. And for many, many young men, an unwillingness to engage longer term in effective care. The danger we end up with a major drug and alcohol problem, major other antisocial issues and social dislocation. It's a classic in this situation that we make the comment often, you don't get well to go to work, you go to work to get well. Someone like Simon needs to be engaged in the appropriate social structures and family structures to remain functional, and within that context to look at the provision of the most appropriate medical and psychological treatments. that might be required. Next slide. Okay, so hopefully these three cases have given you an idea of the sort of considerations that we have when we're trying to put the brain and mind model into practice in each of these issues. Issues in relation to making choices about the person within their social context, trying to get the issues related to stage sorted out with an idea of the intensity of services that might be required on an ongoing basis. The attempt to use health information technologies in appropriate ways to assist assessment and then assist, in fact, the tracking over time. These are important kind of sets of considerations. In this first series of three case examples, we've tried to use three fairly straightforward or indicative cases at each time. The classic, just to consider, regroup. The first one, typical young girl in the middle of exam anxiety, with a background of anxiety that needs to get through that particular period, hopefully learn from the experience, social skills, but progress on an ongoing basis. With a pretty classical hyperarousal anxiety, depression type presentation, but already with significant social anxiety and avoidance. That kind of case often for us gets lost and comes back later on because it wasn't sufficiently dealt with, the opportunity for her then to progress onto post-school educational training in an appropriate way. That's the sort of case for us that often gets lost, and we see 2 or 3 years later when the person hasn't been to university or employment or school for 2 or 3 years and is worse. The second case, and where the situation is 3 years later, more severe, more complex, odd thoughts that need to be pursued, more comorbidity, greater social dysfunction at a later age, and being noticed more by people outside of her family in her wider social situation, and the need to track that. At a critical life point, 3 years into university, if she fails at that point, the opportunity is lost. She's likely to have considerably poorer outcome if not sufficiently treated and if not sufficiently monitored. She's also in that watching category with odd and unusual ideas about her appearance and about her own self and her own identity development, the sort of situation in which we would have a lingering concern or need to make sure that she is not in the early stages of developing a more psychotic-like disorder. So it looks anxious, but it could be one of those ones in which a more psychotic disorder emerges over time, needing to stay engaged, and where we would definitely be actively tracking for at least 12 months during that particular period. The third case, Simon, the young man, different cultural background, particular cultural background, being an Aboriginal person, particular sets of social difficulties that need to be taken account of. However, appears to have quite a long development of a depressive type disorder in a family context of bipolar disorder within his family in his late adolescence that has a more severe depressive syndrome that on clinical examination suggests a need for a higher degree of intensity of care and they're very close monitoring. And in that particular situation, a commitment by services in a multidisciplinary way, working with either employment or with education, but certainly probably working with his family and cultural group to ensure that he gets longer term care. So 3 good examples of the sort of situation we see in young people around the end of the school period, the post-school period, when these disorders often present for care, but need to be managed to different degrees of intensity to actually achieve the functional outcomes we're looking for. All 3 raise the issues around concurrent drug use. 2 of them raise issues around suicidality, needing to be effectively managed on an ongoing basis. All of them actually benefiting from getting engaged with technologies, with actually using self-monitoring strategies as well. Lisa, I wonder if you want to comment about that in terms of when we get through the acute phase, get people out of the hole, the introduction to using technologies. Do you know, getting people to use their phones and their devices to mood track, to monitor, to work with over time as part of that ongoing monitoring process?
Yeah, so young people use apps all the time, so they're quite familiar with it. One of the difficulties is they won't use it necessarily unless it is incorporated into clinical practice. So unless you check in with young people and you use that information in their care, then they often drop out of using those. So they need to understand why it's important, that it will be taken account of, and that it is important in terms of the delivery of their ongoing care and maintaining their recovery, maintaining wellness over time. So if you don't support it, people won't use it.
And I'll also say about these three cases, we've shown the initial assessment phase. When we assign stage, we make a provisional determination of stage. We often don't finalise that within 1 month of actually signing stage, because sometimes people deteriorate. For example, Anne in the middle there might have deteriorated very quickly, developed a more paranoid illness. Simon might have gone on to develop much more clear-cut type bipolar type illness or a more psychotic-like depression in a particular phase. We be careful about the first month in particular, about being too dogmatic about which stage a person is, because people often present in the middle of a crisis in a particular situation. So in each of those cases, the monitoring of the first month very closely in terms of the treatment decisions that have been made, the multidisciplinary aspects that have been set out, and then also the sequencing of care in those particular issues. There are other things that need to be done at the same time. Clearly, with regards to the first case, Jane, educational support through the exam period. So not dropping out on the final school exams, HSC, whatever it is at that particular point that she's doing in her particular state. That's important. And coping and learning coping styles that assist her in the future with those particular sets of issues. So making sure the educational support is in place. With the second case, with Anne, who's in the university type environment and may consideration may require actually working with the education provider to make sure she gets it. Also working with a situation where she's in a share house type of situation. There may be other people that need to be involved. Working with the social kind of elements of that to make sure that culturally we understand what's going on, but also within her particular context that she does actually continue on successfully with her university-based education. And the third example with Simon in the employment situation, trying to find the right sequence between treating his depression significantly, but also attending to that work environment. What would be the type of employment or types of training that he might be supported back to? In each of the situations, being careful about the degree of comorbidity with alcohol and drugs. Often we don't take account of sufficiently, and when that is best addressed in a particular situation. And if there are medication issues to be taken into account, particularly in Simon in the end, if medication is introduced in that particular issue, what would be its ramifications? So just take that final case, Liz, with Simon. The classic in that situation would be prescribing antidepressants in someone in that situation who has a family history of bipolar disorder and has already had hypomanic sets of issues. There would be issues about very close monitoring of antidepressant prescribing in that situation.
Absolutely. Absolutely. The risk of developing more unstable mood and particularly more impulsivity and self-harm is huge. In addition to that, the need to really monitor his physical health outcomes as well, because he is on his particular trajectory is particularly associated with poor health outcomes.
So, in summary, we consider these three cases to be good exemplars of the type of case we're looking at. They all have their own degree of complexity, or even though they're at different stages. They all have their own particular need for care. They all need to be monitored, not only for their symptom set, for where their illness is going, but also for their functional outcomes and the implications. Seizing the opportunity of their presentation for care to try to change the trajectory. Each of the cases had opportunities before where probably not intensive enough intervention or not successful enough in attention, not enough emphasis on following the longer term pattern has meant they've re-presented for care at another point. Sort of thing we'd like to try and now actually get a hold of, actually make a difference so the person not only gets out of the hole, but that they do well into the future. In subsequent series, as part of these case series presentations, we'll look at more complex cases over time and also what treatment decisions happen when treatment doesn't work. Despite our best efforts in many of these situations, we are just dealing with the start. Things don't always go to plan. So actually, we'll also look at what happens when things don't go the way that you predict based on the initial assessments and what other sets of factors look at it. However, it's also the reality that many of the people we come to see are more complex. They're more complex when they started, or as a consequence, as time goes on, they require more complex clinical interventions and more complex case assessment. We hope you join us in the future for those further case series. And thanks for your attention today. Important to say that our work in all this area is supported by a variety of foundations and groups, particularly Future Generation Global, Bupa Foundation, and by the families who have supported our particular work. It's really grateful to those families and to Future Generation Global for the opportunity to develop these particular webinars. We do actually have ways that you can access this material on an ongoing basis, including of the first 6 seminars if you haven't had a chance to actually see them in the past. Thanks very much for your time and attention today.